Welcome to this explainer. Today, we're looking directly at how California is deploying its initial allocation of the CMS Rural Health Transformation Program. We're going to bypass the general federal guidelines and focus specifically on how the state is structuring its programmatic framework, managing its initial federal capital, and strictly complying with federal directives to reform rural health delivery on the ground. Here's our agenda for today's explainer. First, California's baseline award framework, followed by the transformative care model. Then, workforce development implementation, technology and tools deployment, the budget period 1 allocation, and finally, the state program governance structure.
All right, Section 1, California's Baseline Award Framework.
So, looking at the numbers, California received an unrestricted federal award of exactly $233,639,308 for budget period 1. This is fully funded by CMS. This figure is basically the baseline capital the state is using to mobilize its operations. And remember, budget period 1 is really just the starting line of this multi-year federal initiative. The state is required to obligate these initial funds under pretty strict federal deadlines. That means this $233 million figure dictates the immediate scale and speed at which California can actually start deploying its programmatic infrastructure across designated rural counties. Now, you can see here how California's state-level strategy maps directly to the overarching CMS strategic goals. Federal guidelines actually demand that participating states allocate funds to at least 3 designated categories to ensure a comprehensive approach. California answered that statutory call by structuring its implementation into 3 distinct initiatives: the transformative care model, workforce development, and technology and tools. Every single state-level program and budget expenditure traces directly back to one of these core federal mandates, which ensures total compliance with the CMS post-award framework. Looking at an independent analysis of budget period 1, we see a highly sequenced rollout of these funds. There's $104.8 million in published active grants, compared against roughly $128.8 million in unallocated federal funds prior to the obligation deadline. This gap actually matters quite a bit. It tells us that California is deliberately pushing initial capital through distinct, immediate grant opportunities while retaining a substantial war chest, so to speak. That unallocated portion is strategically held back for broader programmatic distribution as the federal timeline progresses, giving the state the financial flexibility to address operational bottlenecks as they pop up.
Moving on to Section 2, the Transformative Care Model.
For its primary operational response, California is deploying a hub-and-spoke model to target medical service study areas and primary care health professional shortage areas. Rather than funding isolated clinics, the state requires the formation of interconnected regional collaboratives. In practice, this means rural hospitals act as essential hubs. They coordinate directly with spokes, which include federally qualified health centers, rural health clinics, birthing centers, and local community organizations. This networked physical infrastructure is designed to keep care local and reduce rural bypass. Essentially, a patient shouldn't have to drive 100 miles for care if their local clinic can handle it, supported digitally or operationally by that central hub hospital. To comply with federal guidelines mandating evidence-based interventions, the state has integrated specific clinical models right into this hub-and-spoke framework. For instance, Project ECHO provides telementorship, connecting specialists at academic medical centers directly to rural primary care doctors to upskill them on complex cases. We also see OB Nest, which sends remote monitoring tools home with expected mothers to drastically reduce long drives for routine prenatal checks. By deploying these proven, outcomes-driven models rather than untested pilot programs, California satisfies the CMS directive to utilize validated care delivery systems that actively manage chronic disease and upskill local clinicians. Strict adherence to federal Category B restrictions is a fundamental part of this implementation. CMS actually caps direct provider payments at 15%. Why? Well, because the federal government refuses to let these grants function as a bailout for struggling operations. Because of that, California defines its transformative payments solely as conditional, milestone-based investments. These funds cannot be used to simply cover ongoing operational deficits or reimburse standard billable services. They're strictly tied to executing the measurable structural changes demanded by the transformative care model.
Next up is Section 3, Workforce Development Implementation.
To address critical clinical shortages, California is building a sequential workforce pipeline. Step 1 is mapping precise capacity gaps at the county level. They're identifying exactly which specialties are missing in specific rural geographies before spending a single dollar. Step 2 takes that data and uses it to fund targeted clinical placement networks, ensuring medical residents actually complete rotations in those identified rural facilities. And finally, Step 3 deploys retention and relocation supports. This looks like localized housing assistance or targeted debt relief, specifically designed to stabilize that workforce, so newly trained clinicians don't immediately leave for urban centers.
It's important to note that California is implementing strict guardrails to enforce a mandatory 5-year rural service commitment. Under federal law, specifically Public Law 119-21, any clinical talent recruited or retained utilizing CalRHT program funds carries this strict statutory requirement. The state can't simply disperse the workforce funds and walk away. It is actively accountable for tracking these clinicians to ensure they physically serve in the designated rural geographies for the entire duration of that 5-year mandate.
All right, Section 4, Technology and Tools Deployment.
This initiative serves as the necessary digital backbone for those hub-and-spoke networks we talked about. You really can't have a functional regional collaborative if the local spoke clinic can't seamlessly view the hub hospital's digital records. Therefore, modernizing electronic health records and establishing robust cybersecurity are baseline prerequisites. Once that secure infrastructure is in place, California is funding the expansion of telehealth nodes and e-consult services. On top of that, patient-facing digital tools, like centralized scheduling apps and shared telehealth portals, will be deployed so rural residents can easily interact with this newly integrated regional network.
Moving right along to Section 5, Budget Period 1 Allocation.
Looking at this precise breakdown, it confirms that administrative costs remain comfortably under the maximum 10% federal limit, sitting at just over $23 million. When you compare the numbers, the sheer scale of California's priorities really comes into focus. The transformative care model receives a massive $112.2 million allocation. That's nearly double the amount for workforce development and triple the allocation for technology and tools. This distribution directly reflects the central role of the clinical hub-and-spoke frameworks in California's operational strategy. It complies with federal spending caps while heavily prioritizing direct structural investments over administrative overhead. Finally, Section 6, State Program Governance Structure. Managing this level of funding requires a distinct oversight mechanism. The Department of Healthcare Access and Information, or HCAI, acts as the absolute lead agency. Now, while the state did establish the Rural Health Policy Council to ensure ongoing public transparency and gather subject matter expertise from rural stakeholders, its function is strictly advisory. The structural hierarchy clearly dictates that the RHPC provides non-binding feedback, which keeps final statutory, operational, and financial accountability centralized entirely within HCAI. This brings us to the ultimate compliance challenge. How will California satisfy the strict federal reporting and performance metrics required by CMS to secure subsequent workload funding for budget periods 2 through 5? The state has to successfully stand up these regional models, enforce the rigorous 5-year workforce mandates, and meet explicit data reporting requirements to secure federal authorization through fiscal year 2030. If the state fails to meet these rigorous CMS metrics during budget period 1, it risks losing its designated share of the remaining federal workload funding in the years ahead. Thanks for joining this explainer on California's Rural Health Implementation Framework.